Okay, and for our last talk of today, I'd like to invite Joanne Lynn. She's a CAN IBD nurse from Oakville, Ontario, who will be moderating our final session.
Thank you, Jennifer. I'm pleased to present Dr. Ashley O'Toole, Adjunct Professor, Queen University, Skin Center for Dermatology in Peterborough, Ontario. Complete undergrad degree in Health Science at the University of Ottawa. Master degree in Health Behavior and Communication at Ryerson University. Complete medicine school at McMaster University, graduated in 2012. 5 years dermatology residency at University of Ottawa. Work as a medical dermatologist at the Skin Center for Dermatology in Peterborough, Ontario. Involved in 20 plus clinical trials in psoriasis, eczema, acne, and a lot of skin disease. Enjoyed teaching medical students and residents and being the mother of a busy 1 year old little boy. Please welcome Dr. O'Toole.
Okay, well, thank you very much for inviting me, and I've been really interested to listen to a lot of the talks today because I found there's a lot of overlap between the medications that you guys use and the ones that we use in dermatology, and you'll certainly see that come up as we go through the talk. So what I'm going to be presenting on today is the skin manifestations of IBD, and I don't have any relevant financial disclosures. So the objectives of today's talk are to review the skin manifestations of IBD and come up with a bit of an approach to how we would go about diagnosing and managing these manifestations. And I'll do a quick approach to wound care, and we'll end with some case presentations to kind of ensure that the points have taken, that you can go home with. And then we'll end with some resources that I find useful, and they may be useful in your clinics or in the hospital ward. So I'll start with a bit of a memory aid that I came up with when I was studying for my final examinations in dermatology. So when I was trying to memorize all the different manifestations of IBD in the skin, I came up with this acronym called Crohn, and it almost spells Crohn's. So the C is contiguous, Crohn's disease. So this would, Crohn's disease, and contiguous meaning that is actually attached to active bowel disease and manifesting on the skin. R is reactive, so these are things that you may be familiar with that we'll go through in detail today. So erythema nodosum, Pyoderma Gangrenosum, polyarteritis nodosa, etc. O stand for oral manifestations of Crohn's disease. N are the more nutritional manifestations, and then M would be metastatic. So this is when it's distant from the active bowel disease, but related to underlying Crohn's disease. So as a overlying summary of all the extraintestinal manifestations of IBD, most of you know that there is obviously joint inflammation that occurs in about 40% of patients. What we'll focus on today are the skin conditions, and that's in about 15% of patients have some form of skin manifestation of their IBD. And then hepatobiliary tract and eye inflammation are also quite common. And you may wonder why we're starting to see these groups of systemic inflammatory diseases that kind of come up again and again in the same type of patient populations. So recently, this idea of immune-mediated inflammatory diseases has come up, and these include systemic inflammatory diseases like psoriasis and psoriatic arthritis, rheumatoid arthritis, ankylosing spondylitis, IBD, and HS. And we're starting to learn more and more that there's a lot of similar inflammatory pathways that are the basis of these diseases, and in that way, they can often be treated with the same treatments. So we'll start with an overview of psoriasis. So many of you may know that psoriasis, this is a chronic immune-mediated disorder resulting from both genetic and environmental influences. About 2 to 4% of the North American population has psoriasis. It has a bimodal presentation, usually presenting either between 20 to 30 years of age or an older at 50 to 60 years of age. And 20 to 30% of patients with psoriasis will have psoriatic arthritis. So we know that there is an increased relative risk in patients who have psoriasis of these other immune-mediated diseases, including IBD. In fact, the risk of IBD is 1.5 to 4 times higher in patients who have psoriasis. And specifically with Crohn's disease patients is a 2.49, or about 2.5 increased relative risk. And with ulcerative colitis, 1.64 increased risk. So you may all recognize that photo there on the extensor elbows. That's chronic plaque psoriasis. So these well-demarcated, silvery scale thick plaques, usually on the extensors, the elbows, the knees, back of the scalp. But there's also many other different presentations. So you might be surprised to know, but all these pictures do represent different variants of psoriasis. So at the top, that is called guttate psoriasis, and guttate is actually the Latin word for raindrop. So it's thought that these little red, tiny papules that have silvery scale are in a raindrop distribution on that person's back. The middle photo is actually an erythrodermic patient with psoriasis, and to define erythroderma is 90% body surface area involvement. And then these hands represent another type called palmar-plantar pustulosis, or palmar-plantar psoriasis. So it does take many different shapes and forms. And then some people just have psoriasis in their nails, or just have it in the scalp, inversely, so in the folds, or even just oral psoriasis. So lots of things to keep in mind. And then we start to look at how we would treat psoriasis. So topicals, potent topical steroids, vitamin D analogs, even tar is used once in a while, and topical retinoids. When we start to see patients who have more than 10% of body surface area of psoriasis, and in our practice we use one whole hand as it represents 1%. So if someone has more than 10 hands or 10%, then you wonder about more systemic treatments. So light-based treatments, so phototherapy is used, or the systemics that you guys are familiar with. From an IBD perspective, we also use in psoriasis, so methotrexate, mycophenolate mofetil, cyclosporin, acitretin, apremilast, and then the biologics. So again, a lot of overlap here, the TNF-alpha inhibitors, IL-12/23 inhibitors, IL-17, and then IL-23 alone inhibitors. So one of the interesting things that Dr. Silverberg alluded to was these paradoxical presentations of psoriasis and IBD. So it's actually twofold. So there are lots of cases of a new onset of psoriasis or an exacerbation in someone who has pre-existing psoriasis when a TNF-alpha inhibitor started for the IBD. The most commonly implicated TNF-alpha that can cause psoriasis in someone you're treating for IBD is actually infliximab. Most patients, as Dr. Silverberg mentioned, can be managed conservatively, like you treat through it, just with some topical steroids or some of your topical treatments, without the need to change the TNF-alpha inhibitor. However, if it is severe, usually discontinuing the TNF-alpha will resolve the underlying psoriasis. And then, like Dr. Narula was speaking to, there have been trials with the new IL-17 inhibitors that we use commonly in psoriasis that have been shown to flare or cause new onset IBD. So that's kind of the opposite of the first TNF-alpha induced. And it's thought that the IL-17 may actually have a protective role in gut, and then so that when you inhibit it, it becomes harmful to these patients. This is just a nice summary slide that looks at all the biologics that are approved now in Canada for treating psoriasis, IBD, and HS. And you can see the one that's yes all across is for adalimumab, which is Humira, and this is usually one of our starter, like go-to agents that we reach for. So the second topic that I'll talk about is called Hidradenitis Suppurativa. This is a condition that's having growing recognition now in North America. People are getting better at recognizing it, and now there's some excellent emerging treatments, so you may see it more and more. Basically, it's an inflammatory disorder that attacks the apocrine gland-bearing sites, so the hair-bearing sites, specifically under the arms, anogenital areas, and sometimes in the inframammary area or in the pannus. Patients complain of recurrent boils, draining sinus tracts, scarring, and then a pathognomonic sign, which is called a double-headed comedone, or a double-headed blackhead, basically. Usually starts around the time of puberty. More females than males are affected. And there's research that's come out in 2018 that quoted a 9 times increased risk in patients with IBD at developing HS compared to the general population. And the risk of new onset IBD is also significantly increased in HS patients. So the relative risk was 2.19 times higher in HS patients. So again, the clinical presentation for HS was these inflammatory nodules, usually sterile abscesses in the folds, very tender, painful, and they can leave hypertrophic scars and fistula, and they can be associated long-term with infections, depression, lymphedema, and fistulas. And if left unmanaged, that chronic inflammation could lead to squamous cell carcinoma. In terms of management, general measures can go a long way for a lot of patients. So weight reduction and smoking cessation are key. Reducing friction and moisture, because these are usually occurring in the folds where there's lots of heat, sweat, and friction. So that's important. And then antiseptic soaps, topical antibiotics can help reduce that bacterial load. Interlesional steroids right into like an active inflammatory nodule can provide symptomatic relief. But oftentimes we're reaching for systemic treatments, so oral antibiotics, hormonal therapies like spironolactone, or starting an oral contraceptive in women can be useful, systemic retinoids, and then again, some of these immunosuppressive agents like prednisone, mycophenolate mofetil, azathioprine, and TNF-alpha inhibitors are often used. And then I have a slide here on that contiguous and metastatic Crohn's. So for the contiguous, if you remember how I said these are typically attached to active bowel disease, the most common presentation is actually labial or scrotal swelling. So in the photo that you see above, that's labial swelling, and that person went on to have a diagnosis of Crohn's disease. And in some cases, 20% have no preceding diagnosis. So this was one of the first initial signs for some people. So it can be labial or scrotal, but also perianal is quite common. And then even attached to like an abdominal surgical site can be a contiguous Crohn's. And then metastatic Crohn's, that's more common. That's a more common picture is what's seen there on the bottom. It can occur anywhere on the body. And if you were to biopsy it, under the microscope, it would look exactly the same as Crohn's from the gut. And these lesions typically respond to treating the underlying Crohn's disease. And then another condition that's probably quite common in some of your clinics is Pyoderma Gangrenosum. So the photo here shows classic Pyoderma Gangrenosum that all the textbooks would have. That's your classic ulcerative disease, but there's also 4 major forms. So ulcerative, bullous, so large blisters, pustular, so large pus-filled blisters, and then superficial granulomatous. The initial lesion starts off as a tender pustule, and it very rapidly spreads to be an impressive ulcer with a necrotic, undermined border that can have purulent or vegetative base. 50% have an underlying disease, and the most common one is IBD in about 20 to 30% of PG patients. Arthritis and hematological disorders are also on the possible causes, so all these patients need a thorough workup. And PG lesions do not typically parallel the IBD activity. So sometimes patients who have had calm IBD for years may present with PG. So you always have to keep that in the back of your mind. This photo shows the bullous type, so large, taut, fluid-filled blisters on the anterior shins. And then going over some management options for PG. If it's just small, you could start with potent topical steroids or topical calcineurin inhibitors. Because this disease is often mediated by neutrophils, which is like your inflammatory cell, you could try some anti-neutrophilic medications. Colchicine, dapsone, or clofazimine have been tried. However, many patients do need some immunosuppressive agents, so that's where we would reach for prednisone, thalidomide, cyclosporin, methotrexate, azathioprine, mycophenolate mofetil, cyclophosphamide, or IVIG. More recently, I've had success putting 2 people on TNF-alpha inhibitors, and it has actually worked quite well. You'd have to ask for compassionate use of these medications because it's not on label at this point, but it was the only thing that worked for both of them. Now that we've covered Pyoderma Gangrenosum, some people may think of possible PG when they see a stoma dermatitis or a stoma ulcer. So I've taken this table from one of my textbooks that I used when I was studying of all the different causes of peristomal disease. And PG certainly is on there, but it's quite infrequent. Other things that you should consider are irritant contact dermatitis. This is the most common cause, usually due to feces or urine exposure. A patient who has a pre-existing skin disease, like psoriasis or eczema, that could also present around the stoma. Infectious causes, so candida or fungal overgrowth, herpes, bacteria, certainly think about that. And then allergic contact dermatitis. This is something we often see in the clinic where patients have been referred. Are they allergic to the paste or the ring or the wafer, the ostomy bag, something that they're coming into contact to? So there actually is a whole stoma allergy testing set that we could do for certain patients. And then I just have a few quick snappers of other skin diseases seen with IBD. You've probably all had patients in your practice that have erythema nodosum. So this is actually the most common skin manifestation of IBD. And you can see in the picture, they're bruised-like, painful, red, purple, subcutaneous nodules, quite painful. Patients may have some systemic symptoms, so fever, joint pain, malaise. Most common on the shins, so the extensor surfaces of the extremities, especially that anterior shin. A biopsy shows inflammation of the fat, although it's often not required and would be slow to heal anyway. So if you could make a clinical diagnosis, that would be ideal. This disease does parallel how well controlled the intestinal disease is. Treatment can be sometimes as simple as stopping any precipitating medications, bed rest, leg elevation, NSAIDs like naproxen. However, some patients do go on to need potassium iodide, colchicine, prednisone, TNF-alpha inhibitors, or even thalidomide. Sweet syndrome is a really interesting condition. The other name for it is called acute febrile neutrophilic dermatosis. Often it presents with these juicy orange-red papules, usually on the torso, and the patients, they can be painful and can also be bullous or have vesicles. Most commonly head, neck, upper extremities, and patients often have eye inflammation with this disease. So it is typically associated with underlying causes, and 20% of patients, this sweet syndrome could present before their IBD is actually diagnosed. Other things could be infectious, hematological malignancies, autoimmune disorders, drugs, and pregnancy. So again, these patients, it's usually a biopsy-confirmed diagnosis, but they need a thorough workup as well. Treatment, they usually respond rapidly to topical or oral steroids. This is a photo of vasculitis, or the full name is called leukocytoclastic vasculitis. These patients have palpable purpura, some hive-like lesions, hemorrhagic macules, and blisters. usually on the lower extremities and dependent areas. And some patients do have some systemic symptoms, so joint pain, GI or GU involvement. A biopsy of this condition would show inflammation of the small vessels of the skin. Usually this disease does resolve spontaneously within weeks to months with some supportive care and NSAIDs and antihistamines. Reasons for treating with prednisone for someone that's presenting with vasculitis would be if it's ulcerating, or if it's severe, like with those systemic symptoms, or if it's above the waist or like progressive. And then I alluded to this earlier about different oral manifestations of Crohn's disease. So the photo on the bottom actually shows this cobblestoning of the buccal mucosa. So the inside of the mouth shows this rough kind of stone-like cobblestone. And if you were to biopsy that, that would show granulomatous infiltrates, just like active Crohn's disease. Linear ulcerations of the oral or the genital mucosa is another thought to be pathognomonic sign for Crohn's. Gingival hyperplasia or nodules of the gingiva, cheilitis granulomatosa. So that's the photo on the top. So those lips are so swollen, and if you were to biopsy that, that would also show these granulomatous infiltrates. So this condition is called Melkersen-Rosenthal. Aphthosis, so canker sores inside the mouth, angular cheilitis, so just inflammation along the lips. And then Pyostomatitis vegitans is a rare mucosal variant of Pyoderma Gangrenosum. And then both of the earlier presenters alluded to this about an increased risk of skin cancer in Crohn's or colitis patients. And it's thought to be possible two reasons. One is that chronic increased state of inflammation, like non-healing sores, chronic ulcerations. If that's left unchecked for a long period of time, it can allow cancers to overgrow. And the second possible cause is the chronic use of different immunosuppressing medications, things like AZA or the TNF-alpha inhibitors that could predispose someone to non-melanoma and melanoma skin cancers. A recent study came out in January 2018 that did show an increased risk of melanoma in both Crohn's and ulcerative colitis patients. That's independent of immunosuppressive biologic use, and their increased risk was around 1.37 times relative risk. And then we know again about the thiopurines with IBD and non-melanoma skin cancer. This is the last slide of different rare associations with skin manifestations of IBD. So the picture on the bottom shows cutaneous PAN or polyarteritis nodosa. This is a medium vessel vasculitis. There's a long worded next disease that's called bowel-associated dermatosis and arthritis syndrome that is sometimes referred to as badass. The first time I submitted a biopsy for this, I wrote query badass for the pathology, and he did not know what I was talking about. Anyway, it's kind of interesting. So these patients present with fevers, chills, malaise, arthralgia, diarrhea, and they have underlying IBD that can be managed with glucocorticoids, AZA or TNF-alpha inhibitors, and it does just kind of melt away with appropriate disease management. And then acrodermatitis enteropathica is typically related to a zinc deficiency. So the last little bit of the talk is a primer on wound care. And this really could be a whole lecture, especially for you guys, because a lot of the IBD patients have chronic wounds, chronic ulcers, and then some of the diseases that I mentioned earlier, things like Pyoderma Gangrenosum or Hidradenitis Suppurativa, they all are these chronic wounds. So to review quickly, there's 4 phases of wound healing: hemostasis, inflammation, proliferation, and remodeling. And when you get stuck in one of these phases, that's when a wound becomes chronic. The goal that we're learning about more and more now is the value for moist wound healing. So it used to be thought in dermatology, like if it's wet, keep it dry. If it's dry, make it wet. but it's actually about keeping it moist. And this helps keep a good wound base, reduces tissue desiccation, retains that important wound fluid that has all your important growth factors, promoting a low oxygen tension, which is important for wound healing, and stimulates the new blood vessels and collagen deposition from forming. One of the nurses that I trained with, and I did a month of wound care during my residency, she taught me this mnemonic called DIME. So I always think about this when I go to see a wound patient on the ward. The D stands for debridement, so making sure that there's no, it's an active, healthy wound base, that there's no necrotic tissue. I is infection, so ruling out, is there an infection that's keeping this wound chronic? And then I also being inflammation. Is there an autoimmune reason why this wound isn't closing? M is moisture balance, so again, that moist wound healing is key. And then E, consider the edge. And then this slide, I think you could probably refer to on your own if it's going to be posted. It's just a quick review of all the different dressing types that are out there now and what an appropriate use would be. Everything from films like Tegaderm, hydrocolloids, hydrogels, alginates, foams, and microbial agents. And then we'll do a little test your knowledge. No pressure. So this photo, I don't know if anyone has any descriptions that they have noticed with the picture. There's actually two. This one and this one, same disease. Yes. And what sort of stuff made you think about that? Yes. Gunmetal gray, that's excellent, yes. So typically described as a purple border, gunmetal gray, very cribiform, which is kind of scalloped border, heaped up edges. And then I put this picture of a peristomal PG, because it kind of alludes to this idea of pathergy, which is where minimal trauma to the skin can make PG worse. So I wondered for this person, was there some sort of dressing or the stoma appliance that created a minimal trauma that left PG at this site? So that's the kind of key things that you may have picked up from that photo. And then I have two here. This is case 2. This is the axilla. Anyone remember what those are? Double-headed comedones, exactly. So again, that's HS, exactly. So abscesses, nodules, inflammatory papules, and then that double-headed comedone. So two blackheads really close together. That's the only thing that can cause that. And then, that didn't show the whole way. Anyone? This actually showed the feet, the full foot. Yes, very good. So non-palpable purpura, so if you touched it, it wouldn't blanch. Bright red, can ulcerate in usually the dependent areas. It's a bit harder. It's juicy. Good. That's sweet syndrome, yeah. Good. And this one's probably easy. Good. That's basically it. Oh, and then I'll quickly go over some resources. So one, we do have a lot of complicated HS and severe psoriasis patients who also have IBD in our clinic. And with our clinic, which is overseen by Dr. Melinda Gooderham, we have over 20 active clinical trials going on right now. So we are using some trials with some even the medications that have mentioned today, like the JAK inhibitors, the risankizumab. We did trials with guselkumab. So a lot of upcoming research there. And then there is a nice specialty clinic here in Toronto, closer to home if anyone's from Toronto, but Dr. Afsana Alavi is a dermatologist here. And she runs not only an HS clinic, but also a Pyoderma Gangrenosum clinic. So if there's ever some complicated patients that you just, even a consultation, and then you could take back over, that would be nice to get her thoughts. And then on the fly, we often use this resource that's created out of Australia, DermNet NZ. Amazing disease summaries, not only for the providers, but also for patients to print out and their families. And then what we use for a lot of our systemic medications is roominfo.com. So if you wanted a handout on azathioprine that would, tell patients and their families what to expect, or the TNF alpha inhibitors, roominfo.com has a lot of good resources. And then 2 handbooks. If you were going to get one for use in your clinic, I would suggest what we call Baby Bologna. It's written by Dr. Jean Bologna. It's a handbook that's a summary of her textbooks. It's called Dermatology Essentials. It's about $65. And then the other one is called Fitzpatrick. Both of them, myself and my other co-residents used for survival when we were seeing clinics and round survival and that sort of thing. So they're both great resources. And that's just the references.
Thank you so much. It was a great presentation. Did any have a question? Yes.
I'm loud. So 2 questions. One is I'm from Alberta. Do you use derm consults in Ontario? Do you have an online platform for consultation?
Yes.
Can you maybe explain that? Because I
Yes.
find it's one of the most useful. It's
Oh,
very
interesting.
functional.
Yeah. So here in Ontario, we have 2 telemedicine resources that for people who are, it's a long wait list to get referred to a dermatologist in their community, or there's just no way that they could travel to see a dermatologist. It allows a primary care provider or even like a nurse practitioner at a clinic to take a photo and have it sent through an online telemedicine service to a dermatologist who's accredited and willing to accept the consults, and they have to respond to them within 24 to 72 hours based on the urgency dictated by the requesting provider. There's 2 services. One is called OTN, so Ontario Telemedicine Network, and the other one is e-consult service. And there's actually reimbursement from both the referring physician, so doing that, because some people might say, oh, it's annoying to take photos or whatever, but they can actually get reimbursed, and then the dermatologist is reimbursed as well. So it's a really nice system and cuts down on consult wait time.
So on follow on to that, I get a lot of photos sent by patients with different rashes in that. So the quality of the photograph, is that an issue, or can I
Yes.
send something that a patient has emailed me?
I believe when you register, because you have to go through a training in order to use,
So I have to be an OTN
Yeah.
user to be able to.
you have to have an account, and then when you get an account, I believe they give you your camera
Oh, I see.
with instructions.
I have to take a picture
Yeah.
and then send it through OTN.
I don't know how the program works here. In Alberta, you have to have the patient there because you actually take the picture
Yes.
with the program
Yes.
open. So it's not on your phone. The picture goes right into that program, and that picture doesn't actually load onto your phone, so it can't
Yeah.
go up to Google or something. And it's actually confidential.
Yeah.
Amazing service.
Yeah, it's called store and forward. So it only takes the photo while the patient's there, and then they leave, and it's not saved anywhere.
Can I ask another question? It's probably one of the most useful derm things I've seen.
Oh.
Like that program is amazing.
Yeah.
The other thing, I have some patients who end up with warts.
Mm.
And it can either be genital warts or with really complex condylomas.
Yeah.
Or warts on their hands. And especially if they're on an immunomodulator, almost impossible to
I
treat.
know.
How do you approach those? Do you use laser, and have you actually ever used injectable antiviral therapies?
Okay. Definitely common for warts in immunosuppressed people, and it's actually if they have confirmed immunosuppression, it is covered under OHIP to treat them, because that's one drawback. If it's like a normal immune person, there's no coverage for it, so then they're paying out of pocket for wart treatment. But if they are on immunosuppressant or an immunomodulatory agent, it would be covered. For treatment, when I was doing my training in Ottawa, one of the cosmetic clinics had a PDL laser, which went after the hemorrhagic vessels, like the pinpoint vessels that supply the wart, and they had good success with it. And for those type of patients, it would be covered. So even though it's done in a cosmetic clinic, it's being reimbursed by the government, so they're not paying out of pocket. They had good success. It's definitely not done in Peterborough. I think it's more of like a specialty clinic thing. I haven't done intralesional like cidofovir therapy, but we have been having success with intralesional candida antigen. So it's brought in from a pharmacy in the US, and it's candida antigen, so the yeast antigen, which is injected in between 4 to 7 units into one wart, like the biggest wart. And it's thought to stimulate the immune system from within to attack the warts, and so they all kind of shrink. So it doesn't go away on like the next visit, but once a month they would come back and they would say, oh yeah, they're smaller, or like half are gone, and then I need another injection, and we've got clearance in a lot of people with intralesional candida. Yeah, I've done it. Yeah. They don't like getting the needle, but yes.
Just behind you, Usha. You had a picture up earlier. It looked like perhaps a child. It looked like genitalia.
Oh, the labia.
Swelling, labia. I forget what the diagnosis was there.
That's the contiguous Crohn's.
Yeah, so I have a patient who had, it's a male, about 38, 40, and he was in my clinic a couple of weeks ago, and he has this, he's on vedolizumab, but he has this brand new intermittent penile swelling that's not painful. It bothers him because he doesn't like the look of it,
Yeah.
right? But it's not painful, it doesn't itch, there's no rash. But he said, well, I have to show you. And I said, all right, show me. So so he shows me, and it looks like, I mean, it doesn't, that looks sore, but it's not sore. It almost looks like somebody took saline and injected it all into his genitals. That's what the appearance. So I was speaking to one of my my medical colleagues, and I said, should this go to urology or dermatology? They said, well, maybe urology. But then I looked at that and I thought, maybe it's dermatology he needs to see.
The thing that's interesting is that it's intermittent. Because I don't believe
that wouldn't be.
No, because if you biopsy this would be actual granulomatous inflammation that would not go away. You'd wonder about things like angioedema, which can be like allergy.
The consult's been sent on. I mean,
It's
was it
relevant,
it
yeah.
was really important. Was it semi-urgent? Well, to this patient it was,
Yeah.
but not really,
Yeah.
right? It's not painful. But when I saw that, I
That's
just thought, could it be that? But that looks much more painful than this
Yes.
gentleman presented
Yeah.
with.
Wow, interesting.
Yeah, it's very unusual. And then he's emailing me daily, asking me if I sent the content. Would I like to see another picture? I said, no.
Daily journal photos.
No, please don't send me a picture.
I had a question regarding practical tips on commonly seen conditions, the angular cleitis as well as reoccurring oral aphthous ulcerations. What are your thoughts on treatments, or what are your tips on treatments?
I think with the angular cheilitis, you have to find out what's causing it. I think the most common cause is just with age and changes in the dynamics of the face, where there's more drooping and saliva collection in older people than they were used to. So for that group of people, it would be like barriers. So even just like Vaseline to that area. Some people might need zinc barrier. And then if it becomes dermatitic, then my favorite option for treating like a lip dermatitis is Protopic, which is topical tacrolimus. It is not a steroid, so there's no risk of thinning the skin. It goes on really nicely, and it treats it within a couple days. The only side effect people can have with that is 10% of people have burning, which is a bit more prominent on the lip, so if they keep it in the fridge, that would really help. And then your second question was about apthi. again, you have to find out why they're getting it. What we typically reach for painful mucosal ulcerations is, I really like Magic mouthwash. Do you use that? So it's a prescription of viscous lidocaine, nystatin powder, dexamethasone solution, something else, and maybe tetracycline capsules broken up. It's a prescription, and most pharmacies know how to make it. It's like a 4-fold prescription that basically covers off yeast overgrowth. It has lidocaine, so it's less painful. It's a steroid to the dexamethasone, so that lowers the inflammation, and then the tetracycline, which is like anti-inflammatory, antibacterial. So most pharmacists would know how to make that, and that's a nice symptomatic relief. And then also just topical Liderm gel, which is this potent topical steroid, is within a day it would be gone with that. I think it's like up to TID PRN. So the other thing we had a talk when I was in training by an oral maxillary surgeon who talked about children's Benadryl, because it's liquid for anyone though, and he says 5 milliliters, swish and spit, and it's like a topical antihistamine, and it makes the mouth feel much better right away. And so that was another go-to that doesn't involve a steroid, so that's a nice one.
The other thing that works well for active ulcers if they're really sore is get them to go buy rice paper wraps that you would use to make like rice paper wrap. Take a little bit of it off and put it over the active
Really?
ulcer. It provides a physical barrier. You put a little bit of steroid underneath it,
Yeah.
and then the rice paper wrap on top. It's like charm. It's like
I like that. That's good.
Hi, thank you very much. I started my career over 30 years ago with inpatients with oatmeal baths, painting them with tar and stockinette, and going home smelling like gasoline. Yes. So we've come a long way. But I just was wondering, for patients that are already on anti-TNF therapy and they start having psoriatic symptoms, how are you able to determine if it's an EIM or if it's from the anti-TNF?
What's EIM? Well, I guess like we work a lot hand in hand with the rheumatologists in town, so they often see our patients. I guess it would be hard. I guess you could try and stop the TNF or switch agents and see if it improves. It would be hard to elicit if it actually is primary. Yeah. Yeah. Unless it quickly followed after a dose escalation or something like that. Yeah.
We didn't talk about fungus. I have somebody who's waiting till January to start her anti-TNF because her toenails are literally thick, all of them, into the moon of the toenails. And the doctor is worried about starting her on anti-TNF. And she can't get in to see until January. But what typically can I, prepare her for? Is there anything that a person can do until they get to see them? She has Crohn's disease. She needs her anti-TNF, but we're afraid that her toes are going to fall off.
I have never heard that as a contraindication, like having onychomycosis to starting a TNF-alpha inhibitor. If you wanted to speed along the process once they get in to see the derm, the only treatment that works for onychomycosis when it's all 10 toenails is oral Lamisil or oral terbinafine, which has its own side effects of liver dysfunction and. Good. Oh, God. So I would, so because of those side effects, I only like to treat with like a systemic agent. It's 3 months of Lamisil. If you prove that it is onychomycosis, so do clippings and send for fungal microscopy and culture, because a derm, that could set you back a month if the derm has to do that on day 1. But if they have the evidence that she comes with on the day of the appointment, then they'll start terbinafine. Yeah.
Any other question? Thank you so much, Dr. Wilkin.
Wow, we are efficient today. This brings us to an end of our program. Before we leave, does anybody have any questions that they would like to put forward? No? Well, I'd like to thank our sponsors today, Dr. Silverberg, Dr. Nabrula, Dr. O'Toole, for very wonderful presentations and giving us a lot of information to take home with us to our practices. I'd also like to thank our moderators today, Joanne, Bobby, and Brenda. Thank you very much for participating. I just wanted to say stay tuned. We do have some webinars planned in the very near future that we're working on. So as long as we have your email address, you'll be on our distribution, and hopefully you'll be able to attend those. So this concludes 2018 CanIBD. Thank you all for coming, and hope to see you next year.